Let's continue on with Chapter 13, Part 2, BLS Resuscitation. And what we're going to look at now is one rescuer adult CPR. And this is where one rescuer is giving both chest compressions and artificial ventilation. And as much as we'd like to think that that's not going to happen, there is that possibility. Because if you and your partner are the only two and you've got to send your partner out to get equipment, you're going to be alone for a few minutes. So remember, in the one rescuer adult CPR, the ratio of compressions to ventilations is 30-2. So there's your suction, and so it's not mechanical, that first device. What that is you, instead of pushing your hands on the sternum, you're going to place your hands on the device and use it to push down and pull back up. And then the rescue pod, which is your ITD, as you can see there, in between the tube and the bag valve mask. We do have other devices, so a mechanical piston device is a gas-powered or electric-powered plunger that puts a piston onto the sternum, puts a device onto the sternum, and then using the piston will compress the chest. You have a load distributing band CPR or vest CPR. These are the auto pulses that we're used to. They will wrap around the chest and then compress, and they'll constrict the band against the backboard, which then squeezes the chest and then release it. But the manual chest compressions, they're the standard of care. The problem with extra devices is they can fail. Batteries can die. They might not fit the patient. So, it's important that you remember that when the devices fail, going back to hands-on is the best way to treat your patient. And this is a picture of the auto pulse, or geezer squeezer, as I like to call it. Unfortunately, we will run into situations where we end up having to do CPR on infants and children. Airway and breathing are the focus of these patients because that's where the problem lies in most of them. Again, I can't stress enough, unless they have an underlying heart condition, it is more likely that their cardiac arrest is the result of a respiratory failure. So what causes the respiratory problems? Well, injury, infection, foreign body airway obstruction, drowning, electrocution, poisons or overdoses. Kids, especially toddlers, can get into a lot of things, and they have that hand-to-mouth problem. And then sudden infant death syndrome are all reasons we'll see pediatric patients go into respiratory arrest and then cardiac arrest. How do we determine their unresponsiveness? Well, we try not to do a sternal rub on our infants and our young children, especially infants. You're going to flick the foot. You're going to try to startle them, speak loudly. We're still going to check for pulse and breathing the same way, except in our infants, we're going to feel for that brachial pulse. Remember, that's in the upper arm. And it should take no longer than 10 seconds. Because their airway is probably what failed first, they've been without oxygen for longer. If it's a foreign body airway obstruction, we need to remember the skills. Infants, the back blows and the chest thrusts. Our children, abdominal thrusts. We need to not put our infants into a standard head tilt chin lift. We need to consider putting them into what we refer to as the sniffing position. I'm sure you remember hearing that. We're going to provide rescue breathing if they have no airway and have a pulse. Not breathing and has a pulse, you're going to breathe once every 3 to 5 seconds. Because remember with these patients that their normal respiratory rate is higher than it is for an adult. So in the adult, rescue breathing is once every 5. In the pediatric patient, especially the younger side, you're going to breathe once every 3 to 5 seconds. If they're not breathing and have no pulse, we're going to do 30 compressions to 2 breaths. So we're going to give 2 breaths after every 30 compressions. CPR is crucial just as it is in any other patient. We need to ensure that we are providing the best rhythm, rate, appropriate hand placement, and we need to transport appropriately. We shouldn't be waiting on scene if we're ready to go for an ALS provider. If we need to get ALS, we should maybe meet them en route or just get to the hospital to get them additional care. Whether it is a pediatric or an adult, your goal is not to interrupt CPR more than a few seconds at a time. You need to remember that the longer you interrupt CPR, the longer your patient is going without oxygen. So consider making sure that 60% of the time, at least, is how long you're doing chest compressions. So out of the 100% of time you're doing CPR, 60% of it should be your compressions. So when do we not start CPR on a patient? Well, first off, if the scene's not safe. If the scene isn't safe, you shouldn't even be close enough to know that your patient needs CPR. If the patient has obvious signs of death, so they've got non-survivable injuries, they've got rigor mortis, so the body is stiff, lividity, decomposition, these are all issues that tell you that this patient's been down longer than is survivable. This is a picture of lividity. So down in the lower part of the picture on the right-hand side, that's where pressure was on the ground. So there wasn't the ability to for blood to get there. And as the patient laid there dead, the blood pooled in the areas that didn't have pressure on them. When do you not start CPR? Well, if they have a DNR and you have it. As we talked about under legal issues, if your patient's family claims that they have a DNR, but they don't have it, then you've got to start CPR. If the patient, if you've started CPR, don't stop it. Remember, don't stop until you've verified with the docs. But if you arrive on scene and they give you the DNR, you still have to make sure the patient's actually deceased, but you do not start CPR. Okay, so why do we stop CPR? Well, we stop it using a STOP acronym. And that seems pretty silly, but it'll help you. So we stop it when a patient S starts breathing. Remember, CPR is only for those patients who aren't breathing and don't have a pulse. So if your patient starts breathing and gets a pulse, you should probably stop beating on their chest. We're going to stop CPR because T, they're transferred to another provider. So you're going to stop it when there's someone else to take care of them. You're going to stop CPR when O, you're out of strength. Not just tired, but physically incapable of providing high quality CPR. You should recognize this coming and make sure there's someone in place to do it for you. And then you're going to stop CPR because P, a physician, tells you it's acceptable. So like you start CPR on a patient and then they find the DNR, you still have to wait for a physician to tell you to stop. Remember, foreign body airway obstruction is a BLS skill. So you've got to remember that there's a lot of reasons. It's not just food. It could be blood or damage, dentures, vomit, all sorts of things. Anything that gets into the airway and obstructs it and doesn't allow your patient to breathe effectively, that's a foreign body. Oftentimes it occurs during a meal in adults. In children, it's a meal or at play. You've ever got a food so good that you just want to eat it without chewing, and then you choke on it. Yeah, that's you. Just be glad you didn't have to call 911. My own youngest son, he still thinks it's a great story, was eating gummy worms, and I turned around, and he hadn't chewed it. He was probably 2 years old, hadn't chewed it appropriately, and choked on it. And I turned around before we could get stopped. He had reached into the back of his throat and pulled the worm out whole. And still laughs about that. We do have patients who will have mild airway obstructions where they can exchange air. There's some distress, but not significant. We don't do anything for these patients because what we do could actually harm them. So we need to recognize the sudden severe obstruction. These are the patients who are going to be doing the universal sign for choking. They're going to be taking action and trying to dislodge whatever it is themselves. We also need to remember in unresponsive patients that we need to consider foreign body airway obstruction if once we've opened the airway, there's no air movement, and once we give 2 breaths, it doesn't go in. So the Heimlich maneuver on responsive adults and children older than 1, when there is no airflow, when it is a severe obstruction, is the step you take. And again, here's your standing abdominal thrusts with a fist at the belly button, and you're going to go up and in as you squeeze. When you've got a patient in advanced stages of pregnancy, squeezing the abdomen, probably not going to happen, or patients who you can't get your arms in the appropriate placement, then you're going to use chest thrusts. So you're going to put your hands on their chest like this. The goal is to force air up towards whatever the obstruction is to get it to move and dislodge. In our unresponsive patients, once we've opened airway and checked breathing and recognized that there is a foreign body airway obstruction, you are going to look in the mouth, and especially in your adults, and you're going to remove that obstruction if it's there. And if it's not, you're going to do abdominal thrusts. Remember that, again, that foreign body is a common issue associated with infants. If there is signs and symptoms of an infection, though, so they've got runny nose, they're coughing up a lot, the parent tells you, then don't try to dislodge the foreign object. It's likely it's thick sputum that's blocking the airway. You're going to manage your responsive and unresponsive children that are greater than 1 year of age the same way you would an adult. So the Heimlich maneuver, or you're going to do the abdominal thrusts. You may have to get down to their level like this picture shows, but your hand placement is still the same and the motion is still the same. We don't use abdominal thrusts in infants. We use back slaps and chest thrusts. So remember, the heel of your hand should hit them in between their shoulder blades. And then the chest thrusts are going to be the same as if you were doing CPR. So back slaps and chest thrusts. Making sure when you're doing the back slaps that you're kind of holding the airway open so that if something does come out, it can be removed appropriately. When your infant is unresponsive, you're going to start CPR. And don't check that pulse before starting compressions. The compressions are both to, if there's no pulse, move the heart, compress the heart, but it's also to move that obstruction. We don't do blind finger sweeps in our infant. We're going to look to see if the object's there, and if not, keep going. Some special circumstances you're going to run into associated with resuscitation. So if it's an opioid overdose, if there's a suspected drug overdose, we're going to have to give naloxone administration, so Narcan, because in an opioid overdose, you might be moving oxygen but it's not going to help your patient unless you stop the absorption of the opioids. And then you've got to consider that your pregnancy, your cardiac arrest during pregnancy, there's a lot of anatomical issues associated with it. And you've got to make sure as you're giving CPR that the baby hasn't rolled into a position that's going to constrict the vena cava. So you've got to position your pregnant patient appropriately to support that. If you stop CPR on scene, you need to speak with them. You need to be warm and sensitive and calm. Use their name, use the patient's name. You know, explain to them the process and why. And do this if you didn't start CPR. Make sure they understand that you know the physician that you spoke to agreed. You know, and use clear language. As we've talked about, this is an emotional time. You need to be supportive. Ask if there's someone they can call. If law enforcement's on scene, make sure that they don't need any help with any information. And make sure that if there are children at the house, that they're included or being remembered as or a high five or a touch on the shoulder. We've got to practice CPR. CPR is one of those things that we take for granted and say, no problem, I'll remember what to do. But you can become poor in your CPR skills if you don't do it. So we like to see refreshers on CPR. It's why CPR expires. According to the state, we don't require you to maintain CPR after you've gotten out of EMT class, but most departments do. So make sure you're taking, refreshers and you're including CPR as part of your practice and your ongoing education.